So good afternoon to everyone. This is Marina Vivarelli from Rome in Italy, and I'm really delighted this afternoon to present what I think is going to be a truly fantastic talk. Our speaker this afternoon is Professor Francesco Trepiccione from Naples. Francesco Trepiccione is an MD PhD who has dedicated his research activity to renal, clinical, and experimental physiology. He now is in charge of the dialysis unit of the nephrology division at the University of Campania, Vanvitelli. And he trained first getting his PhD in Denmark at Aarhus University, and subsequently finalizing his PhD education first at the NIH in Bethesda, and subsequently at INSERM in Paris, France. He has performed both basic research and more clinically focused research, both in mouse models and in patients with different forms of tubulopathies. Since then, he has been focusing on different forms of rare renal diseases, mostly nephrogenic diabetes insipidus, hypokalemic tubulopathies, renal tubular acidosis, and Fanconi syndrome. He has also recently been awarded the ERA Stanley Sheldon Award for Young Investigators in Translational Science. So this afternoon, Francesco Trepiccione is going to speak to us about glycogen storage disease 1B and 11, the disease mechanisms, and novel treatment. So over to you, Francesco, and thank you so much for participating.
Thank you, Marina. Thank you, everybody, and good afternoon. I'm really honored to give a talk to this curriculum, and my presentation will be on glycogen storage disease, a group of disease that are in between the metaburn and all the metabolism expert and the kidney work, so the ERKNet. This is mainly due to the similarities of the proximal tubule cell with the hepatocyte. So I will briefly introduce the physiology of glucose transport in the proximal tubules, and then give you some insight on these two disease, glycogen storage syndrome type 1B and type 11, by showing you experimental model and also clinical data. So let's get started by looking at the protagonist of this talk, that is the proximal tubule. I think you are very familiar with this picture here, and as you can see, the proximal tubule is composed by a convoluted segment and a straight part. The first one is located in the cortex, the straight part or S3 segment in the outer stripe of outer medulla. This different location is also associated with a different function and ultrastructure. As we can see here, the S1 that is now here in blue is composed by a very cylindric cells, very rich in mitochondria, and with a very high brush border. This is mainly because it has a very high reabsorptive capacity. The S2 is becoming more and more cubic as the S3, and you can see that the brush border is shortening. These three segments are also quite different in glucose reabsorption. The bulk of glucose reabsorption, actually, the majority, is uptake in here in S1 and S2, but some of these can even be reabsorbed in S3 segment. So the protein that are expressed in these three segments regarding the glucose reabsorption are different. And here in this cartoon, I can show you how this occurs in S1 and S2. On the apical side, there is this SGLT2 transporter that is becoming very famous in CKD and diabetologists because of the new class of drug, glycogen, that are able to interfere with this reabsorption function. This is able to reabsorb glucose coupled with sodium, and then the glucose is going to be reabsorbed in the bloodstream through this facilitating transporter that is called GLUT2. As you can see here, this passage is really fast, and the glucose is not involved in any metabolism in the proximal tubule cell in normal condition. Indeed, this cell is not fueled by glucose, but by free fatty acid, glutamine, and lactate that have a part of their metabolism also in mitochondria. So now you can see why the proximal tubule cell are the richest in mitochondria among all the kidney cells. Out of this metabolite, the proximal tubule cell can start the production of new glucose in the form of glucose 6-phosphate. And this process is very well known as gluconeogenesis. This glucose here indeed can exit the cell by means of this apparatus here that is located on raw endothelium reticulum, and is made by a transporter of glucose 6-phosphate inside the rare, and then it's phosphatase by glucose 6-phosphatase, and also here without a phosphate group the glucose can exit the cell. Only two kinds of cells can do that, hepatocyte and proximal tubule cell. And with this activity, the proximal tubule contributes to 25% of fasting blood glucose homeostasis. So it's a very important condition. And when these transporters are impaired, this leads to clinical relevant conditions as glycogen storage disease 1B, when the transporter is not working properly, the 1A when the enzyme is failing, and the 11 when the GLUT2 is not working. So we will speak about the glycogen storage disease 1B and 11 in the rest of my talk. These conditions are characterized by a sort of Fanconi-like syndrome. This is because not all the symptoms and signs that you know very well associated with proximal tubule dysfunction are present at the same time in all these diseases. We will see in more detail later. So the glycogen storage disease 1B is a very rare condition. It's a systemic condition in which the kidney is involved, but also other organs except the liver are involved. So the patients present with neutropenia and neutrophil dysfunction. This is, we will see why the neutrophils are very important, and they actually made a big impact on the patients actually, but also the liver is involved not only with hepatomegaly, but with a series of metabolic defects like lactic acidemia, hypoglycemia, hyperuricemia, and dyslipidemia. And the kidney is involved with a mild Fanconi-like syndrome. Glycosuria can be or not present, low molecular weight protein is present, but the most important thing is that around the second and third decade of life, these patients are affected by CKD and usually require renal replacement therapy. We investigated here a mouse model of GSD-XI by using a conditional knockout system that has been generated thanks to the Italian Association of Glycogenosis by Alessandra Eva in Genoa. And this system is inducible, it means that when we give a doxycycline and doxycycline here, we can suppress the gene expression of the G6PT. And as you can see here, this in all the kidney zone, as you can see. And the phenotype that we generate is very similar to what is going on in patients. They develop glycosuria, these mice, phosphaturia, and low molecular weight proteinuria. And when you look at the histology of the kidney, you can see that the proximal tubule, that this is proximal tubule usually, you can see here in the knockout mice that is completely swollen and present this white vacuolization. These findings actually were observed at the beginning of 900 by a Napolitan anatomist that is called Luciano Armani in patients with diabetes mellitus in the pre-insulin era. So this condition can be really a model to study also a very epidemic disease as diabetes mellitus. All this morphology is associated with an alteration of all the key crucial protein for the function of proximal tubule, like NAP2A, NH3, aquaporin 1, and so on. And the content of glycogen in this kidney is abnormal, is 6 times more than normal kidney. As you can see here, the swelling of this cell was due to glycogen deposition, as you can see here in the cytosol. And this cellular swelling is associated with a reduction in the expression of the glucose machinery, as we think a feedback condition. The model that we thought was working in this type of glycogenosis was is represented in this cartoon. When G6PT is not working, we have an accumulation of glycogen 6-phosphate. But we think that this is not the only glucose 6-phosphate that can contribute to glycogen formation and synthesis, since the gluconeogenesis is give only a limited contribution to this. We thought that the glucose that normally is entering this cell and freely going out from the cell is at some point trapped here. And to be trapped, it needs to be phosphorylated in position 6. And so they need this enzyme that is called exokinase 1, that is normally not expressed in proximal tubule cell. This will boost the glucose 6-phosphate presence and then lead to a huge glycogen accumulation and cell swelling. We thought that then, by limiting the glucose intake by applying this dapagliflozin, we could clear the glycogen inside the cell. So we treated this. First of all, we went to in vitro and we used this mice proximal tubule cell that were silenced for G6PT. And this was associated to an increased expression of exokinase 1, and both at immunoblotting and transcript level. And this was associated also with an increased activity of this enzyme. So the HK when in this kind of model is playing a role. And when we treat this cell with dapagliflozin, we could see that we can prevent the glycogen accumulation, and the glycogen level, you can see, goes back to the control level. And we have a shift from a glycogen synthesis enzyme, metabolic enzyme, to a glycogen lysis enzyme that help clearing all the glycogen that is stored in the proximal tubule cell. But the big impact is on the histology. You can see here that knockout mice present all this vacuolization that with pseudo color is represented by this blue here. When we treat with dapagliflozin, everything or the majority goes away in a much more similar way as in the control. So this is associated with the restoration, as you can see here, of all or the majority of the protein involved in the proximal tubule function. And this is a clear benefit for the mice, since phosphaturia is reduced, and as you can see, this is associated to the presence on the apical membrane of this red color here, that is NAPI2A, while before in the knockout, before treatment, this is retained in the subapical domain of the proximal tubule cell. So a benefit for the mice level for the kidney, according with this model that summarizes our finding. The loss of function mutation make in some way the expression of isokinase 1 and then shift the glucose entry towards glucose metabolism and glycogen synthesis. By stopping the fueling of glucose to this cell, we could help the clearance of glycogen. Actually, while we were working to this model, a manuscript was published showing that these SGLT2 inhibitors, and in particular dapagliflozin, another one we used dapagliflozin, was also helpful for the neutrophil function. Indeed, these neutrophils rely their metabolism, energetic metabolism, on glycolysis. And so they really require a functional HK1. However, they show here that in these neutrophils, this system made by G6PT and its phosphatase is involved in the clearance of products that can interfere with the metabolism of this cell. So these two enzymes contribute and are defined as metabolite repair enzyme. That basically means that they help to detoxify some of the metabolites that can interfere with HK1. One of these metabolites has been identified in 1,5-anhydroglucitol that is quite similar to in the structure to the glucose 6-phosphate, but has a super inhibitor activity on this HK1. And actually, we show that applying the SGLT2 inhibitor in GSD-1B neutrophil derived from these mice is functional to restore their several of their function. And this has been proved also in this very rare condition called severe congenital neutropenia. And the data from this severe congenital neutropenia are shown here. You can see that when applying dapagliflozin, the level of 1,5 Ag goes down, and together with this, it is restored the number of granulocyte compared to the untreated mice. We show similar data in GSD-1B mice and in the neutrophil derived by that. So actually, this SGLT2 is beneficial not only for the kidney, but also for the neutrophil of these patients. how this SGLT2 inhibitor can act on neutrophils. Actually, there is not a direct interaction, but again, back to the kidney and back to the proximal tubule, the model that is considering the most let's say potentially most accredited working hypothesis see this system. The SGLT2 here transported in S1 and S2 is not able to reabsorb 1,5-nitroglycerol, while the SGLT4 and 5 on S3 it can. And it contributes to the reabsorption of the majority of this compound. This is a compound that we usually get from diet, and especially these patients for cornstarch diet that they take for the hypoglycemia and liver abnormalities. When we apply an SGLT2 inhibitor, we actually increase the glucose delivery to this point, and then the glucose reabsorption becomes the prevalent metabolite to be reabsorbed. And by competition, 1,5-CAG is not reabsorbed anymore, and we lose it with the urine. So by increasing the urinary clearance of 1,5-CAG, the SGLT2 inhibitors are believed to be beneficial also for neutrophils. And we have now clinical data that demonstrate this. There are a lot of case reports that indicated that SGLT2 inhibitors can be effective in these patients by reducing the neutropenia. And the MetaBurn recently has retrospectively make a survey of 112 patients with GSD-XI, in which they showed that as compared before the Dapagliflozin treatment, there is a significant amelioration of the number of neutrophils in these patients, both in pediatric and adult patients. And this is associated with a reduction of EBD, so inflammatory bowel disease, that is one of the clinical feature of these patients. And this is associated finally with a reduction of the use of granulocyte stimulating agent. Of course, there are some adverse events, but this retrospective analysis does not allow us to identify whether or not this drug has an impact in some of the metabolic defect, like hypoglycemia or let's say ketoacidosis or lactic acidosis, because these are one of the features of the disease actually. And what we can see that of course there is a genital tract infection also in these patients, but this is also common because of glycosuria. Okay, we can go on now on the glycogen storage disease 11, and I will tell you a quite similar story with some data that we also collect with the ERKNet, and I'm sure that many of you has contributed with this data. This was required because the Fanconi-Bickel syndrome is very rare. Actually, we don't know we still don't know the prevalence, and so we don't know clearly the clinical spectrum. This is a condition that, just to quickly remind, is due to a loss of function of GLUT2 and is associated then with glycogen deposition in proximal tubule and hepatocyte. So the patient has hepatomegaly. So we collect about 61 patients by sending this survey through the ERKNet, SPN, ERA, and Italian Society of Nephrology. And these were the countries that mostly contribute, as you can see, not only Europe, but we have also some contribution from extra EU countries. We got a slight increase in male compared to female, and mainly pediatric patients, of course. But of course, we had also some patients up to 40 years old, I have to say. So this was mainly also likely due to the fact that some of the patients are lost at follow-up for this condition as well as for rare disease. Regarding, no matter of where you are born in Europe or extra-Europe countries, we could see that about 15% of the kids were born preterm and with a low body weight, as you can see here. And among the symptoms that guide the diagnosis, there was glycosuria, of course, failure to thrive, hypophosphatemia, hepatomegaly, and with a variable frequency, metabolic acidosis, polyuria, bone alteration, that means rickets, and hypokalemia, as you can see here. We don't know if this condition at the moment, this is an unmet, if this condition leads to CKD, but from our data, it seems to that this is not the case, both for children. This is up to 15 years old. You can see that the serum creatinine is in between the normal range, except for some point here, actually quite lower than normal range, likely because they have low body weight at presentation. But also in the adult patients, we cannot see any CKD patients. All of the patients were presented with the creatinine around 1 milligram per deciliter. They were profoundly hypouricemic, as you can see here, both male and female here as with different color dots present with a very low uric acid level, and this is also involving the proximal tubule secretion of uric acid mostly, and while serum potassium was present and low only in 50% of the patients, both male and female. Both when we consider as a threshold 3.5 or 3.8, not all the, let's say, hypokalemia is not a hallmark of this condition, but can occur, can be associated to this condition. While hypophosphatemia and low bicarbonate and so likely metabolic acidosis are mostly present in these patients, as you can see here, both in adult and children. So to summarize the clinical feature of this condition in comparison with the glycogen storage disease 1b, Fanconi-Bickel syndrome has no involvement in leukocytes, so no leukocyte abnormalities. They have hepatomegaly with hypoglycemia at fasting, but this is not associated with lactic acidemia, hyperuricemia, and so on. They have a much more frank Fanconi-like syndrome compared to GSD-I, and at least from the data we have, it seems to be no progression towards CKD in at least up to 40 years old. To better investigate the mechanism of this condition, we study an experimental model of Fanconi-Bickel syndrome by inactivating in the proximal tubule, only here, this transporter, gluteum. As you can see here, GLUT2 is not present in our kidney, in the kidney of these mice, but only in the liver, or only in the liver. So this is a kidney-specific model. And this kidney-specific model recapitulates all the features of the patients as glycosuria, osmotic-driven polyuria, and normoglycemia. Actually, since they have a lower threshold in glucose uptake, they really can better cope to a glucose load compared to the control mice. They present with renal proximal tubular acidosis, as we show here by loading acutely with sodium bicarbonate. You can see that we could make these mice to have similar serum bicarbonate, but when we reach this point, the bicarbonaturia was much higher in knockout mice compared to control. That this is a diagnostic test that we do in our patients to assess a proximal tubular renal tubular acidosis. And phosphaturia was present and very large in these mice. This was mainly due to a downregulation of NaPi2A in the membrane fraction of the proximal tubule cell. And we ask here whether these mice also could still present some sort of glucose reabsorption. So you will see here that in red is the proximal tubule, and we make an experiment in live microscopy in which we trace the glucose with a green fluorescent tag, and we can see here the reabsorption of glucose. You can see all along the proximal tubule that became yellow now, and so this in the control is efficiently reabsorbed, and we cannot see any glucose in the distal tubule here, as you can see. In the knockout mice, the picture, the scenario is quite different. You can see that these mice present with yellow dots in their parenchyma, and these are mainly due to glycogen accumulation. But still, when we load with glucose, you can see that a sort of reabsorption is occurred. We can quantify this, but of course here the glycosuria is present, because you can see in the distal tubule there is still some green fluorescent, while in the control is not. And when we quantify this, we could see that the uptake of glucose was much lower and fast in the knockout mice, and here is significant. So they can still take some glucose, and but not at the same extent of where is going this glucose, since they don't have anymore the exit site on the basolateral cell. It's making glycogen. Indeed, you can see here that in a time-dependent model, these mice accumulate glycogen in the proximal tubule, and this is a picture from EM of knockout mice in which glycogen is accumulated and stored in autophagosomes here. Back in vitro, we tried to evaluate what was going on when the cell was silenced for this GLUT2, and you can see here. I hope you can see, but the heat map is a bit small, that there is a profound dysregulation of gluconeogenic and other metabolic activity, including the lysosomal autophagy pattern. And this was clear here. When these cells were cultured in normal glucose, there is a lot of lysosome and autophagosome that are accumulating in the cell. But when we reduce the glucose in the media, this was much better. So showing that this dysfunction, lysosomal autophagy dysfunction, was dependent by the glucose content and the glucotoxicity. So we thought that this cell could benefit by the treatment with SGLT2 inhibitor dapagliflozin in order to stop the glucose entry and so to don't make any more glycogen in here. And this was the case actually, as you can see, when we add dapagliflozin for 1 month, we could see a downregulation of glycogen content in proximal tubule mice, an amelioration of phosphaturia and metabolic acidosis, and several patterns and key markers of proximal tubule function were restored or tendentially restored. Then we try to see if in patients was a similar story, because our mice model was biased by the fact that was not a systemic model of FBS, because both liver, pancreas, they still had the GLUT2. However, the global knockout of GLUT2 knockout is not livable, and so it's not very well useful for making this experiment of renal physiology. So we went back to the patients and we tried to treat these patients, a 30-year-old boy with genetically proven Fanconi Bickel syndrome. We treated with dapagliflozin for 1 week with 5 milligrams, then for 10 for the 3 months with 10 milligrams. And this, of course, was done on top of electrolyte replacement therapy. We could not see any major effect on liver function, glycemia, and any other notice like a urinary infection and so on. Just to show you some insights, we could see an amelioration of serum phosphate from 1.4 usually to 1.89 in these patients, and back to lower level in the recovery period. And this was associated with an exploratory endpoint as the NEPI2A expression in extracellular urinary vesicle that was slightly increased compared to baseline and recovery period, of course. We also had another exploratory endpoint by measuring glycogen content in the urinary shed cell, so in the urinary sediment. And we could see that in the treatment window, we could see a downregulation of a reduction of glycogen content. And then this goes back again after 1 month of recovery. And so hopefully these are signs that, let's say, make proof of concept for a space for this treatment in this condition. So just to summarize you all the things that have been touched in this presentation, we identify some crucial element in the glycogen storage disease, at least in the kidney, that any impairment in the normal machinery of glucose reabsorption stimulate HK1 activation, and this switch the normal glucose trafficking towards the metabolic trafficking and stimulate glycogen deposition. And this can be prevented by the application of dapagliflozin, and I think also other SGLT2 inhibitors, and it could be useful, at least in the experimental model of GSD-XI and 11. And then dapagliflozin could be very promising in patients with Fanconi Bickel and so glycogen storage disease 11. The others has already proved that for the GSD-1b is a very important piece of treatment nowadays, especially for the exposure to infection and autoimmune disease. Finally, as a conclusion, I show you a translational approach to find and help these patients with rare disease that are orphan of treatment to reposition some drug. And SGLT2 now that is going to be for a long time used, and so they are quite safe. And I think we can move on applying to our patients to give them some possibility. With this, I want to thank you all for listening, and of course, I have to acknowledge all my group here, collaborator in Genova for the GSD-1, in Naples for the GSD-XI, and of course Rick here from Aarhus University that help us with the EM. Of course, the Patients Association, the iGlyco, and the funding that we received for this study. Finally, let me remind you the next webinars that will be held by Pascal Ollier on renal calcium handling, and but then in May on Bardet-Biedl, and in June on podocytopathy. With this, I will be happy to answer your question, if any.
Thank you, Francesco. That was really, really excellent. And as we're waiting for some questions to come through, I wanted to ask you a couple of questions myself. Obviously, we're all really interested about the use of dapagliflozin, and we still don't have a lot of experience in the pediatric population. So first of all, I was wondering, what do you think in terms of how early this treatment needs to be, especially in the phenotype that can lead to CKD? So in the glycogen storage disease type 1b, do you think this is something that people need to worry about, or do you think it will be able to in some way reverse also when there is already some renal insufficiency? Is this something that the mouse model has been able to inform you of? And so how early should we start thinking about this in these patients?
Okay, Marina, thank you for your question. Actually, this is really a crucial point. It has been used also in children in this cohort, huge cohort that the colleagues from the MetaBert have shown that already in 2, 3, 4 years old patients, there are reports it can be useful, and actually it can improve quite soon actually the neutrophil counts. From mice model, we I would say as soon as possible. We made 2 different experiment. The data that I show, in which we had quite a complete reversal of the phenotype, was done as a preventive action. So we start the drug at the same time as we suppress the gene, so we generated the disease. But we have data also that this was effective also when we start later on, but then we need longer time for recovery. I would go as soon as possible, and I would start the treatment.
But would you still try it if you had a late diagnosis? Do you think it still could have the potential to be effective, even in a patient that already has, for example, moderate CKD?
We can, for today it has been approved already for CKD up to 20, a filtrate of 20 ml per minute. So, and these are large number from the DAPA-CKD trials. So I think this could be applied also in our rare disease patients. And in these GSD-1b patients, actually, there will be another important benefit that is immediate for neutrophils, at least what they show.
Okay. Another question I had regarding dapagliflozin was, what about the long-term tolerability? So if people have to take it for a long time, does it tend to give more problems or less problems? And, you know, what is their experience for that? Is that something that in children we should be worried about or not?
I think we should be worried about the IBU and the genital infection, and so I'm wondering in children that are already not autonomous in voiding the bladder, if this could be a factor leading to an increased risk of infection or genital infection. But actually, as we do for diabetics, this can be withdrawn and then
restarted.
Yeah.
Okay, so you don't think that would be, and anyhow, would it happen frequently?
I'm sorry.
Sorry?
For any other long-term side effect, we don't know actually in this condition.
Okay, so then I had another question. What about the effect of hyperglycemia on neutrophils in regular diabetes? Is there any evidence that the mechanism of impairment and so their increasing susceptibility to certain types of infections goes through a similar mechanism? And so I know that dapagliflozin and empagliflozin are already used in diabetes, but is it possible that it can help these patients even from this point of view? Is there any evidence looking at that?
Actually, in this patient, I mean, if I correctly understood the question, this patient have hyperglycemia only after meal, and dapagliflozin is we don't know actually if it's increasing the rate of hypoglycemia. By speaking with colleagues that have used it, this was not the case in the few patients that they treat, but we miss a comparative study so on. So basically the cohort that I show you that the metaburn collect, I mean, as not a control arm. So we don't know if the rate of hypoglycemia and infection is, increased or not with this drug. So this is the first thing that we should, as a community of experts and people caring with rare disease, try to answer somehow. The other face of the medal is whether people with diabetes mellitus can have benefit on neutrophil function by using this. This, I don't know if the same mechanism can be applied to diabetes. I can tell you that in some diabetic cohort, this compound 1,5 Ag, 1,5-anhydroglycitol is high also in diabetics, but I'm not sure whether this is high enough to be toxic for healthy neutrophils, where healthy means that they have a safe and correct metabolic enzyme repairing system. I hope to have answered your question.
Yeah, absolutely. Okay. If I'm not mistaken, I don't think there are any other questions that have come through. I would just give maybe a minute more if anyone has any questions. But no, I don't think there are any more coming through. Okay, so at this point, I probably would wrap it up if there aren't any more questions. And I really would like to thank you so much. This was absolutely fascinating. And we had a very ample participation. And I think it was also a very, very nice demonstration of a collaborative in which both ERKNet and the different societies managed to contribute patients to give, you know, to shed light on these ultra rare diseases. So this is something that we need to try to foster as much as possible moving forward. So thank you to all the participants, and thank you, Francesco, for giving a clear and super interesting talk. And see you at the next webinar on April 25th. And have a good afternoon to everyone, and thank you again. All best.
Ciao,
bye. Thank you. Bye. Ciao.